This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday morning conference. Our speaker this morning is Dr. Graham Smith. I will mention I do have to probably leave before Graham's done with his talk, so I will not be there for the question session at the end. But I want to thank Graham for giving this talk this morning. Graham is a first-year fellow in our clinical track. Many of you may know him at this point. He's an Atlanta native. Did his undergraduate studies at Davidson College, came to Emory, came back to Atlanta for medical school at Emory, and did his residency here as well. And as you can see, he's going to talk to us this morning about antibiotic prophylaxis. So take it away, Graham.
All right. Thanks, Dr. Williams. Like he said, for those who don't know me, my name is Graham. I'm a first-year clinical fellow, and appreciate you guys listening in this morning. I'll be talking about antibiotic prophylaxis, particularly for the prevention of infective endocarditis, and just kind of going through the guidelines here, kind of the history of the guidelines. I have no disclosures. So for my objectives, we're going to briefly touch on the pathophys of infective endocarditis at the beginning. Then we're going to kind of go through the history of the American Heart Association, or AHA's, guidelines for antibiotic prophylaxis, and how they've changed over time, and significant developments. And then we will review the rationale and some of the evidence behind the current guidelines that are actually based on the 2007 guidelines that still hold true. And then finally, we will look at some studies that have looked at the effectiveness of the current guidelines to see if they've actually missed the boat, or if, to see the incidence of infective endocarditis over time. Okay, so first starting off, we'll just briefly go through some of the pathophys of infective endocarditis. I think you guys might be familiar with some of these steps, but I think it's important to establish these again. But the first kind of step in this process is you have turbulent blood flow, which can be in high to low pressure, going, in chambers going from high to low pressure or across tight valves. This damages the endothelium of valves or the surrounding areas, and that leads them to be susceptible to deposition of platelets and fibrin. The deposition of this platelets and fibrin leads to the formation of non-bacterial thrombotic endocarditis, or better known as NBTE, on the surface of these valves and other sites of endothelial damage. And then you have to have some bacteremia. The bacteria then will adhere to these areas. And then you have finally proliferation of bacteria within a vegetation, and you start to get signs and symptoms of infective endocarditis at that point. So here is a really, kind of blown up image, autopsy image of vegetations on mitral valve. This is actually Viridin strep, which is the main bacteria I'll be focusing on in this talk. So going back to go through a little history, the link between oral microflora and infective endocarditis goes back for a while. Thought it was interesting, even going back to the days of Osler. He gave a famous speech to the Royal College of Physicians in London back in 1885, where he, it was clear they already recognized that the oral cavity could be a source of bacteria that causes infections involving the heart. He's also, one of the many things he put his name on is the Osler nodes, the painful raised lesions on hands and feet caused by a complex immune complex deposition, which is a well-known sign of subacute bacterial endocarditis. So before we go through kind of the older recommendations from the AHA, I thought it was good up front and kind of high yield just to make sure we see the most current recommendations, and this is them right here, particularly for antibiotic prophylaxis for dental procedures, because I think this is the most common thing we get asked about in clinic or by patients. And I'll go over this in more detail a little bit later, but I think it'll be interesting to see how, looking at this up front and then kind of going through the old recommendations and how they compare will be interesting. But as for, currently the AHA recommends just giving antibiotic prophylaxis to these 4 very high risk groups of individuals with these cardiac conditions, namely prostatic valve, cardiac valves or material, people who've had previous infective endocarditis, those with congenital heart disease, but with these specific criteria that we'll talk about a little bit later, and also those who've undergone a cardiac transplant, and where the transplanted heart has issues with its valves. They also need prophylaxis for the current guidelines. And notedly, the current guidelines are pretty simple. Most adults can just take 2 grams of amoxicillin just 30 or 60 minutes before the procedure. And antibiotic prophylaxis is not recommended for GU or GI procedures currently. So, like I said, I'll be talking about a little bit of the history of the AHA statements on this matter. It goes all the way back to about 1955 when they first published a document in circulation titled Prevention of Rheumatic Fever and Bacterial Endocarditis through Control of Streptococcal Infections. And they, at that time, left it pretty general for the recommendations for prophylaxis, basically saying patients with rheumatic or congenital disease, it's a good idea to give them antibiotics beforehand. Going forward a little bit, the 1957 recommendations, again, left it very general. Patients who have rheumatic or congenital heart disease didn't really go into much more detail than that. And they mentioned for procedures, they would like patients getting dental extractions, manipulation of the gums, removal of tonsils or adenoids, and also they included at the time GI or urinary tract procedures. And they also included childbirth in those guidelines as well. And I included this slide just to show you how kind of complex the antibiotic regimens used to be. So this is the one from the 1957 committee recommendation. So you had to take penicillin for 2 days prior to your procedure, 4 times per day. The day of the procedure, you had to continue taking it 4 times per day, PO, and then also take an IM penicillin injection 30 to 60 minutes before. And then they recommended taking penicillin up to 4 times a day, 2 days after the procedure as well. So pretty complex regimen that would be tough, very tough to adhere to. So going forward a little bit, through the 60s, some of the developments were in 1960, it was the first AHA statement that recognized the emergence of penicillin-resistant oral microflora that was resulting from all this penicillin that was being used for this prophylaxis. And then in 1965, there was the first document that was just on the prophylaxis of infective endocarditis. Didn't really include anything else about, details about rheumatic heart disease and other things that have been included previously. To keep going forward, in the 1970s was the first time that the ADA, or the American Dental Association, endorsed the recommendations, and it became included to put in there, make sure the importance of good oral hygiene, which is pretty self-explanatory. But they, from that point, they made a good, they really stressed the importance of that going forward. In 1977, they ended up categorizing patients into high and low risk groups. And I'll show you in a second, but that resulted in many complex tables with tons of footnotes, and it was really hard for patients and providers to actually follow the recommendations because of it was pretty complicated. So here's an example of the table from the 1977 guidelines. You can see here that they kind of broke it into high risk, who would get regimen B, and then low risk would get either regimen A or B. And I'll show you what those regimens were on the next slide. But high risk was considered prosthetic heart valves, and then low risk was some congenital heart disease and rheumatic heart disease, mitral valve prolapse, and idiopathic hypertrophic subaortic stenosis. So different valvulopathies. And you can see all the, all the footnotes and caveats. So it was, they're doing their best attempt, but it was, it would become much more simplified in future guidelines. And here's just a quick look at the antibiotic recommendations from those guidelines in 1977, just showing you again the different recommendations for the more higher risk patients. And for regimen B, they would have to get penicillin plus streptomycin, and then for the lower risk, they would recommend just penicillin. Again, moving forward in 1984, efforts were started to be made to simplify these regimens a little bit. You can see this table that I included here from this recommendation, kind of breaking it down into what, when is it recommended, when it's not recommended. And then at this time, they also simplified, this should be pre-procedure prophylaxis to only just one dose of antibiotics. They didn't have to, take 2 days before, the day of, and then 2 days after anymore. And you can see here, still included is rheumatic, heart disease, some mitral valve prolapse as well. So it still included a wide swath of patients here. So 1997 was a big, shift in the recommendations. This is actually the last recommendation made by the AHA before our current guidelines, the ones that I mentioned at the beginning that were made in 2007. These were really important because it acknowledged the fact that most cases of infective endocarditis were actually not attributable to these invasive procedures, but actually a result of these randomly occurring transient bacteremias from routine daily activities, such as things related to oral hygiene, manipulations of the gums, and things like that. And it also was important because ampicillin was introduced instead of penicillin as kind of the go-to antibiotic at this time. So here's a breakdown of the 1997 AHA recommendations. They broke down patients into high risk, moderate risk, and low risk, where low risk didn't need any prophylaxis before procedures. And those included mitral valve prolapse without regurgitation, people with history of rheumatic fever without significant valve dysfunction, some more simple congenital defects, previous cabbage, and so on. Also in low risk, pacemakers or defibrillators was in that category as well. Those with high risk, they again were recommended to get 2 drug regimen. This time it was ampicillin plus gentamicin. High risk again was the prosthetic cardiac valves, those with history of bacterial endocarditis, and then they started kind of breaking down congenital heart disease into different categories that we'll talk about a little bit later with the current recommendations. And then the moderate risk group ended up recommending just doing a single dose of antibiotic, not having to get the gentamicin added on as well. And I thought this was a pretty interesting schematic. Now in the current guidelines, we don't recommend antibiotic prophylaxis for any mitral valve prolapse, that doesn't include the other categories right now. But back in 1997, they recommended if you thought someone had mitral valve prolapse, if you heard a murmur, then they had to get prophylaxis. If you weren't sure about the murmur, you would send them to get an echo. And then by Doppler measurements, if they did end up having mitral valve prolapse, you would go ahead and start on prophylaxis. So moving forward again, the 2007 guidelines represented kind of the big paradigm shift. And like I said, these are actually what the guidelines today are based on. And they included a number of rationales as to why they made the changes they did. Some of those included, like I mentioned before, that infective endocarditis actually results from frequent exposure to these random bacteremias rather than these procedures. And they actually acknowledged for the first time that prophylaxis only prevents a super small number of cases of infective endocarditis in patients who undergo these procedures. And it's mostly related to transient bacteremias. And they also acknowledged, the risk of antibiotic-associated adverse events, including antibiotic resistance, and also, allergic reactions to antibiotics as well. And again, emphasized the importance for oral health and hygiene. So I thought this was really interesting that they included in the 2007 guidelines. They looked at a number of different studies. A lot of this came from like the dental literature, looking at how often people are exposed to transient bacteremias with, kind of everyday activities. Brushing and flossing was 20 to 68%. Use of toothpicks was 20 to 40%. Even just eating was 7 to 51%. Extraction, of course, was more. Surgery was more often as well, and then even just routine cleanings, up to 40% of the times you had exposure to transient bacteremia. So just going more in depth into these rationales. So the idea behind reducing these recommendations was, if we're not going to give antibiotic prophylaxis for people with all these daily activities that expose them to transient bacteremia and potentially infective endocarditis, why do we have so much people caught up in these groups where we're actually prescribing antibiotic prophylaxis for these procedures? So that was really like the main rationale, was trying to cut back, and it really emphasized the need to limit antibiotic use for only those with the highest risk of serious adverse outcomes for infective endocarditis, to try to cut back on the use of antibiotics. So part of the paradigm shift for the 2007 guidelines was really focusing more on those at highest risk of adverse outcomes from infective endocarditis, instead of those at higher risk of getting infective endocarditis. And this was because, like mentioned previously, there was really no good evidence that showed that prophylaxis was preventing cases of infective endocarditis, only a very, very small number. So the authors reasoned that the antibiotic prophylaxis should only be given to patients who are most likely at risk for bad outcomes. And bad outcomes in their mind, were heart failure, complete heart block, need for surgical valve replacement, and death. And I thought this was a good quote that kind of captured that mindset by the lead author, Dr. Walter Wilson. He said, that was the major change that drove everything else in our decision-making and preparation of that 2007 document. That change was two different words: the risk of to the risk from. And here again is the table for the current recommendations that I'll go into a little bit more in depth here. The people at highest risk, they divided into 4 categories. These people were at highest risk for serious adverse outcomes that I just mentioned from infective endocarditis, compared to other patients who got infective endocarditis. And those were people who had pre-existing prosthetic cardiac valves or material, which included transcatheter implantation, prosthetic valves, cardiac valve repair devices, annuloplasty rings and clips. And also this included people with LVADs or implantable hearts. People with previous infective endocarditis, particularly those with Veriden's strep endocarditis, needed prophylaxis for dental procedures. And then congenital heart disease, they eliminated some of these patients and now just recommended the prophylaxis for unrepaired cyanotic congenital heart disease, which includes palliative shunts and conduits, repaired congenital heart disease with residual defects, and completely repaired congenital heart disease just during the first 6 months after the procedure. And then the 4th high-risk category is cardiac transplant recipients who have a cardiac valvulopathy. So why these major changes, and what were they? As you could tell from comparing it from the old guidelines, antibiotic prophylaxis is no longer recommended for mitral valve prolapse, rheumatic heart disease, bicuspid aortic valve, or atherosclerotic valve disease. And the main reason for this was that the patients in the categories I just mentioned, all the data was suggesting that when they were at not as high risk of complications from infective endocarditis as those 4 high risk categories that are actually included in the guidelines now. And again, that there was no strong evidence that prophylaxis prevented infective endocarditis in those groups as well, led to this recommendation. So just trying to cut back on who is going to get these antibiotics. Here is kind of a simplified diagram looking at which procedures need antibiotic prophylaxis according to the recent guidelines. So when prophylaxis is recommended, those are dental procedures which involve the manipulation of the gingival tissue or the periapical region of the teeth, which is kind of down where the roots go into the gums. So definitely including like root canals and things like that. And it also includes routine cleanings. Respiratory tract procedures, the only ones that involve incision of the respiratory mucosa, so bronchoscopies without biopsy would not fall into the guidelines as needing prophylaxis. And also procedures on infected skin, which I didn't know that was part of the guidelines, but if they have areas that are getting kind of worked on that are infected, you need to give them prophylaxis as well. Other more kind of superficial dental procedures, prophylaxis is not recommended. Injections through non-infected tissue, taking dental radiographs, orthodontic procedures, and then people who just have trauma, oral trauma that's not significant. GI tract procedures no longer is prophylaxis recommended for those, or genitourinary tract procedures. They also removed the suggestion to get prophylaxis during childbirth as well. Just to kind of round out some other scenarios where prophylaxis is not recommended that might in your mind think be reasonable. As I mentioned before, electronic devices such as pacemakers, defibrillators, you do not need prophylaxis. Septal closure when the closure is complete. Peripheral vascular grafts and things used for hemodialysis access. And of course, coronary artery stents, CNS shunts, and also IVC filters. You do not need prophylaxis, not indicated in those situations. And the rationale behind that was infections of these devices are rare, but when they happen, they're usually caused by staph and not strep, so usually not related to oral flora. So what are the current kind of simplified recommendations for antibiotics for prophylaxis? Like I've touched on before, it's just a single dose for most patients of amoxicillin 30 to 60 minutes before the procedure. If you're unable to take PO medications, you can get 2 grams IM or IV of ampicillin or cefazolin or ceftriaxone. For allergies, they no longer recommend clindamycin for allergies to penicillins. It's actually would be Keflex, azithromycin, or doxycycline. So the evidence for the current guidelines. So this is going back to the 2007 guidelines. They basically did a large literature search from 1950 to 2006, looking at all the different terms that might be included for these guidelines. And they also searched like the reference list of those papers, and used also various in vitro studies and data from kind of the dental literature as well, and to come up with all these recommendations. Interestingly, there's no randomized prospective data. Most of this data is all even now is all kind of based on retrospective stuff. And then the most recent statement by the AHA is a 2021 scientific statement. It actually didn't update any of the recommendations. Its goal was to look back and see if the changes made from the 1997 to 2007 changes, if they actually resulted in any type of worsening outcomes from Veridan's group strep endocarditis, or if it resulted in increased frequency of morbidity or mortality of this type of infective endocarditis. So looking to see if taking off these recommendations, scaling them back to see if that actually resulted in increased cases of infective endocarditis or not. And it actually, when they reviewed all of the available data, most of the data or the preponderance showed that it hadn't led to an increase in frequency, morbidity, or mortality from this type of infective endocarditis. And they decided with this statement not to make any changes to the 2007 guidelines. They're still hold true today. Some of the methods they used for their study, similar to the ones used in the 2007 study, they did a large literature search. They also, teamed up with different societies, including, Infectious Disease Society and the ADA, the Dental Association as well. And they compiled a large table, which I'll show part of in the next slide, about, just detailing different studies that looked at this question of the incidence and morbidity and mortality from infective endocarditis after the 2007 guidelines, trying to look at any change. So here's just a sample of that large table that they compiled of these different studies. Largely, most of the conclusions were that these changes in 2007 did not lead to an increase in the incidence of Veridan's group strep endocarditis. For the most part, there were a couple studies that did show some conflicting data, and there's been some papers written that criticize this, their findings here. But for the most part, the evidence seems to point towards that not creating more problems with this type of infective endocarditis. This is just a further study that looked at to see if there was any change of the incidence of this type of endocarditis after the 2007 recommendations. They looked at data. They looked at data from the Rochester Epidemiology Project and found that there was no change, similar to the paper before. Like I mentioned, there actually was, a couple studies that were conflicting with the 2001 scientific statement by the AHA. There was one published in 2015 by Pant et al. That used a nationwide inpatient sample, a big database, and they actually did find an increase in the incidence of infective endocarditis caused by strep, although no significant change in hospitalizations or staph endocarditis. This study had several limitations that have been criticized. They didn't have any data on or any information about the antibiotic prophylaxis prescribing in these patients where they had these cases, and they also did not perform a change point analysis, which is a type of statistical analysis you can run to kind of look at changes over time and if they're statistically significant or not. Just some more reasons why we want to limit the use of antibiotics when we can, of course. Luckily, the risk of antibiotic adverse reactions that are serious with these medicines, especially amoxicillin, are very, very rare. Clindamycin, just to note, is no longer recommended as an alternative to ampicillin for people who have a penicillin allergy. There have been multiple studies that show that clindamycin actually causes more frequent severe allergic reactions than the other recommendations. And it's also shown to have an association with C. diff. One study I looked at actually attributed almost 15% of cases of C. diff in the UK to uses of clindamycin for antibiotic prophylaxis for dental procedures, because that was their main go-to as their alternative in the UK for a while. And like I mentioned, doxycycline and Keflex are safer alternatives for people with penicillin allergies. Antibiotic resistance is another important consideration to limit the use of antibiotics that helped kind of form these guidelines as well. As we all know, the antibiotic resistance is a big issue that we deal with almost every day in the hospital. The CDC reported that it was responsible for, recently, it's about 5 years ago, 23,000 deaths, 2 million infections, and roughly 2 billion in excess healthcare costs annually in the U.S. We need to be good. So, for those reasons, we need to be good stewards of antibiotics, and important to limit and follow the guidelines when it comes to giving antibiotic prophylaxis to our patients. So here is a quick case that illustrates some of the changes in the guidelines, particularly from 1997 to 2007 when they scaled back some of the recommendations. So I'll just quickly go over this one. A 28-year-old mother comes to a primary care clinic with her 6-month-old daughter to establish care for her daughter and herself. The mother has a history of a surgically closed VSD with a small residual defect. She's been relatively healthy. Her last visit with her cardiologist was at the age of 18, hasn't had any issues since then. Her daughter is healthy except for a small restrictive VSD that they'd say will not need surgery, but the defect will not close. And so you're trying to discuss the new infective endocarditis prophylaxis guidelines with her, which could kind of be confusing in this situation. And she's wondering why she was told she needs to continue prophylaxis while her daughter does not. And so the key point in this case is that the new guidelines, like I showed you, recommend only for certain types of congenital heart disease. And in this case, the mother would still need prophylaxis because she has a small residual defect after a closure attempt, whereas the daughter just has a small restrictive VSD that will not, that has not been intervened on and probably won't need to be intervened on, and is not, does not meet like the criteria for prophylaxis because it's not complex cyanotic congenital disease. So other interesting considerations, scenarios you might run into. So if prophylaxis is for some reason forgotten or not administered before the dental procedure, it is okay to go ahead and give the dose of amoxicillin 2 hours after the procedure with pretty similar results. Prophylaxis at the time of vaginal delivery is not included in the guidelines anymore. Although there is some controversy and some back and forth on that as well. It's not included in the European Society of Cardiology guidelines either. Another thing that I thought was interesting, that there's not been much data on if tattoos increase the risk of infective endocarditis. So, in roughly the past decade, there's been 21 case reports of that, but that's still kind of a further area of study. The guidelines at this point don't recommend prophylaxis for people getting tattoos or different, body art. But it was in a survey of up to 60 congenital cardiologists, they would recommend for this prophylaxis for their patients with complex disease getting such procedures. So to wrap things up, I think the big take-home points is that we really know what the current guidelines are, which I have here again in this table. Been trying to emphasize that there's the 4 high-risk group of patients that are at high risk for adverse outcomes is the key that I mentioned previously. And just briefly, so that's prosthetic cardiac valve or material, previous infective endocarditis, congenital heart disease with those specific caveats, and then cardiac transplant recipients who have had issues with their valves. And again, it's just for most adults, it's a single dose of 2 grams of amoxicillin 30 to 60 minutes before the procedure. Prophylaxis is not recommended for any GU or GI procedures anymore. And the main rationale for the update for the 2007 guidelines that still hold true is the idea of focusing on limiting adverse outcomes of infective endocarditis rather than limiting the acquisition of infective endocarditis. And again, just a good emphasis on oral hygiene is key as well. I know that can be difficult, especially for many of our patients at Grady. We actually had in residency a doc phrase that you can steal from me that has a list of all kind of the affordable dentists in the area near Grady that they can go to because, at Grady, unfortunately don't provide much dental care there, and it's a pretty big need for our patients. Here's just a quick look at the references for the talk. And I appreciate you guys listening. I don't think Dr. Williams is around anymore, but if you guys have any questions or comments or any concerns, we'll be happy to hear those.
So, hey Graham, this is Neil Dickert. I'm Robbie's fill-in for the sort of question and answer period, so I can sort of help step in. I have two questions. I'm curious about whether you ran across in reading, and the answer may be they're just not great data, but I'm curious about this. One was, as someone who spends time in the echo lab, the relationship obviously between age and atherosclerotic valvular disease and whatnot is obviously significant. You can often look at echoes and get a sense of how old people might be, or certain comorbidities that are associated with extensive calcification. I'm curious as to whether anyone's ever done sort of epidemiologic studies to look at whether this is something that really substantially increases with age, or whether it's something that is just kind of a fixed rate of occurrence across the age span. The second question I was a little curious about is, the emphasis on good oral hygiene seems really important. Have people tried to sort of look at risk stratification on that end? So in other words, are people with worse oral hygiene, at substantially high risk in a way that we need to think about? Have people looked at potentially treating them differently? So age and oral hygiene, are any data that you ran across?
No, I didn't see anything looking specifically at age. And are you referring to like the development of like non-bacterial changes on the valves with age?
Yeah, you look at significant, whether it's mitral annular calcification, sclerotic aortic valve, these kinds of things that you see happen that are normal changes associated with age, that if sort of, for lack of a better way of saying it, rough stuff in your heart, there's a potential nidus for infection. If that was a really big risk factor, then you would think we would see substantial increases with normal age associated changes.
Right. No, yeah. I agree with you. I didn't see anything in particular about age, but I agree that makes perfect sense that people, as you get older and have more, niduses for bacteria to adhere to, that you'd be at higher risk. I wonder if that one day will make it into the guidelines, something based on, if we can split people up based on age, and even, even scale it back even further, maybe have some age cutoffs for certain things. But yeah, that would be interesting. I didn't run into anything with that though. And then your second question on kind of, were you asking about if there's been studies looking at, oral hygiene and kind of, like really trying to break that down and how that relates to the risk of the incidence of endocarditis?
Well, my question was, it seems like we focus a lot on, if you think of two ends, right? There's the portal of entry piece, and then what it's going to get stuck on piece. Right. And we think a lot of, in our world, we think about risk stratification in terms of the heart. I just wonder whether anybody's investigated an approach to risk stratification that focuses more on the mouth, or other kinds of ways of thinking about who might be at risk for having this. If you look at everybody who gets endocarditis and you take pictures of their mouth, what was it? Right. Was it predictable? Because they, or is this something that seems totally random and there's no way to risk stratify on that end? I was just curious as to whether people have investigated that approach.
No, I think that's a good question. I didn't really run into that either. I think, maybe if I had searched through some more of like the American Dental Association papers and data, maybe they have looked at that in more detail, or maybe OMFS kind of literature might have something on that, but that's not something that I ran into. No.
I'll open up other questions that people have for Graham.
Graham, this is Matt Topol. Oh, sorry.
Go, Matt.
Hey, so great talk and timely. I just actually had a patient in clinic who I inherited from cardiologists who've been following him for a long time. History of bioprosthetic aortic valve replacement about 10, 12 years ago, doing well, had 2 dental related episodes of endocarditis, and then ended up having bioprosthetic valve complications from the second bout of it, had to have a valve and valve TAVR from that. And he is in his late 80s and is worried about getting dental procedures anymore. And he's like, it's not so bad. I can deal with the pain in my mouth. I'm like, well, maybe we don't need to be resorting to just having your teeth fall out of your head. Is there any literature on intensification or sort of next steps in terms of recurrent, very complicated episodes of endocarditis for whatever recommendations for prophylaxis, antibiotic prophylaxis would be, so that patients can actually keep getting their dental procedures done?
Yeah, let me go back to so this doesn't say kind of explicitly here about that scenario, like with recurrent bouts of endocarditis, if you really change up the antibiotics. But in some of the papers that I read, those people, might benefit from like IV or IM prophylaxis instead of the PO. I didn't, actually put a charter paper of that in here, but I do remember running into that. So there might be some benefit just based on the things that I scanned through to using the IV, or the other drug classes. That had that patient been just getting the amoxicillin, do you know what they had been getting?
I haven't had a chance to go all the way back and try to figure out. He told me that, the way he described it is he took it, an oral medicine 2 days before and 1 day after, like the day before, the day of, and then the day after. So I imagine it was amoxicillin.
Yeah.
3 doses or something like that.
Yeah. I mean, I don't know, like with any certainty, but I do remember coming across that. So I don't know. It might be worth, and there might be something out there about recurrent endocarditis and kind of what switch ups you can make. Yeah. Because there are so many different options, listed on the recommendations.
Graham, some of our patients are allergic to everything, including everything that's listed down there. Do they have another list of suggestions or just consult infectious disease?
Well, I think, important point is, I think over 90% of patients who report a penicillin allergy don't really have any real issues with it. I think that's one of the allergies that kind of gets carried on from when they're little and maybe had a little rash or something, and it just kind of sticks with them. So I think it'd be good to try to really clarify if they've had, what type of reaction they had and when it was. I think there's some good infectious disease society guidelines that kind of have really tamped down the worry about penicillin allergies. But yeah, and I know it can be tough when patients are saying they get allergic to everything. So these have been shown to be really safe. There's a lot of data from the UK as well that go over millions of doses of these medicines, and some of them show 1 or 2 reactions from 1 million doses. So it's something to kind of reassure your patients with.
Great. Well, if there are no other questions in the chat or that people have, we can sort of wrap this up. I thank Graham for a really nice presentation about an issue that certainly everybody needs to, we all need to be aware of and think through. I think it's also really humbling in the sense that we're a field characterized by large clinical trials. It's not unusual to see cardiology trials in the 10 to 20,000 people range. And when you look at the incidence rates of this, it clearly demonstrates that randomized trials will never possibly be able to answer these questions because you're looking at incidence rates that are so low. So it's a humbling problem in that respect. But thanks so much for a great overview of an important topic, and we'll look forward to seeing everybody next week. Have a great weekend.
The preceding program is copyrighted by Emory University.